You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for October 28th, 2022. This week, a brief follow-up from last week's discussion of Erase AF, recreational drugs, Etripamil, misuse of science, and diabetes as a cardiovascular risk factor. First, I want to thank the Royal College of Edinburgh for inviting me to speak, especially Drs. Ann Scott and Andrew Flapan. Thanks also to the many doctors who spent time talking with my dad, who went to Scotland with me, especially you, Mark Dweck. My assigned talk was Evidence Translation, Lies, Damn Lies, and Statistics. It was a fun lecture, one that I had not given previously, and I told it in chapter book stories. Okay, first topic. I want to do some follow-up from my coverage of the Erase AF trial last week. Now, this was an atrial fibrillation RCT of PVI versus PVI plus low voltage ablation in patients with persistent AFib. And the surprising result of Erase AF was that low voltage ablation led to a statistically significant 38% reduction of first recurrence of AFib versus PVI alone. And in my comments last week, I praised the fact that the authors tested their idea of identifying and targeting low voltage areas in a randomized trial. I pointed out that the prior evidence of additional ablation beyond PVI was extremely pessimistic. Adding ablation beyond basic PVI had found previously to offer no benefit. That's why Erase AF was so notable. It's the first trial showing that ablation beyond PVI definitively reduced first AF recurrence. Now, another point I made was that only 1/3 of the active arm actually had any low voltage areas in the atrium to ablate. Yet Erase AF was still positive. This, I said, was akin to a drug trial being positive despite the fact that only 1/3 of the patients in that arm got the drug. Now, the pessimistic Bayesian priors, plus the fact that only 1/3 of the active arm patients got the intervention, led me to raise the possibility that the positive study was due to performance bias. In other words, operators just did better PVI in the patients randomized to the low voltage arm. Now, senior author Christopher Perkowski and I communicated by email. He made some important points that I hope TWIC podcast listeners would be interested in. The first is that Erase AF is the first study that's documented the fact that 2/3 of persistent AF patients were low voltage area negative versus 1/3 had low voltage areas. That the majority of patients with persistent AFib had normal electrical substrate helps explain why so many of the previous trials have failed to show any benefits from additional ablation. In other words, you don't want to ablate normal tissue. Perkowski emphasized, and I think he's right, that Erase AF is the first study that acknowledges and really exploits the different phenotypes in patients with persistent AFib. They're not all the same. While we have generally felt patients with persistent AFib represent more advanced AFib, the documentation that most of these patients do not have demonstrable electrical disease is potentially really important. So the benefit of Erase AF can be explained by both ablating the electrical substrate that was present and not ablating patients with normal atria. Perkowski also noted that the ablation of low voltage areas in Erase AF included great care in ablating the low voltage area and creating block in the lines that transected the low voltage area. Now, I want to reiterate the notion that good trials often lead to new areas of research, and I think Erase AF has done that. The field now should work to confirm and build on these results. I want to know if A, if these results hold up in longer than 1 year, and it may not. And B, would this reduction of AFib lead to better quality of life or perhaps lower stroke risk? And C, can others duplicate these results? Next topic are drugs that associate with atrial fibrillation, specifically recreational drugs. The UCSF group, led by Dr. Greg Marcus, first author Anthony Lin, have published an observational study in the European Heart Journal regarding the association of recreational drugs and AFib. This, they write, is the first large longitudinal cohort study examining use of cocaine, methamphetamine, opioids, and cannabis with the risk of incident AFib. My friends, this is going to be a short topic. All 4 of the drugs associate with a higher incidence of AFib. Of course they do. This is a nice study of adults who received care in the California Emergency Department. The authors used a bunch of statistical methods to adjust for confounders. Cannabis use had the weakest association of the 4 drugs, but it was still significant. Practically speaking, cannabis association with AFib may be the most clinically significant of these 4 drugs because legalization of cannabis in a lot of states is surely leading to more of its use. Now, the thing is that if a person is doing these drugs, having AFib seems very low down on the diseases to worry about. Even if the associations with AFib were weak or null, my advice to people is still to avoid cocaine, meth, and opiates, period. Take meth, for instance. Relative to your teeth falling out, I'm not sure higher AFib incidence really rates on the worry scale. And as for cannabis, we definitely need more studies on its efficacy and harms for medical uses. It could be that the conditions that cannabis is being used for is the actual causal agent in AFib in this case. All right, next topic is a potential new treatment for supraventricular tachycardia. The drug is Etripamil. It's not yet approved, but it rhymes with Verapamil. Etripamil is a self-administered nasal spray that can be used to terminate SVT acutely. The drug is a calcium channel blocker similar to Verapamil, and it reaches peak effect in 10 minutes, and the antiarrhythmic effects start to wane after about 30 minutes. It's not yet FDA approved, but the drug maker, Milestone Pharmaceuticals, announced in a press release recently that the drug met its primary endpoint in a study called the RAPID trial, which randomized patients to Etripamil versus placebo. The primary endpoint of SVT termination was 2.6x more likely in the active arm. The company also said they did a pooled analysis with a previous trial called Node 301, which that trial didn't technically meet its primary endpoint. The company also reported acceptable safety and tolerability of the drug. They plan to present detailed results at the AHA meeting coming up in 2 weeks in Chicago as a late-breaking session. They also plan to apply for a new drug application at FDA next year. And I highlight this because I think this drug could have a niche, right? Here's why. SVT is one of the most preference-sensitive decisions we have in EP. SVT is rarely life-threatening, so I offer patients 3 options. No treatment, of course, other than education on how to terminate episodes, daily drugs like beta blocker, or catheter ablation. Now, many patients, after hearing the discussion, especially the part about it being not life-threatening, choose to live with the SVT and they go for termination of the arrhythmia. In my younger days, I was enthusiastic about ablation, but I still love ablation. But I now realize many fully educated patients do fine without an invasive procedure and as-needed measures. Let's talk about that as-needed treatment. Normally, this entails resting. You have to get adrenaline levels lower. Then, after a period of getting your adrenaline levels lower, doing a Valsalva maneuver. The thing is that Valsalva doesn't always work, and when this occurs, the patient has to go to the emergency department, which is expensive and time-consuming, and often means getting adenosine, which is one of my least favorite drugs because it causes so much distress. Patients hate adenosine. I call it the heart stopper. It's terrible. Anyways, a nasal spray that could help terminate SVT and keep patients with infrequent but prolonged episodes out of the emergency department could be a potentially handy drug. Now, the other thing with SVT is that it often goes dormant or stops, so an as-needed treatment for SVT with a nasal spray may allow for the natural history to eliminate the problem itself. Now, we'll see the actual data at AHA, and then if approved, cost will be a big factor, as it is with any new and novel drug. I am afraid that a useful drug could become cost prohibitive for many patients. All right, so this is the big topic of the day, is this misuse of science. The Heart.org Medscape Cardiology has a long-form features article on the important topic of the misuse of scientific data. The author leads the story with an egregious case of violent misuse of a social science paper. But then she delves into the more common forms of misappropriation of science. Say, when a controversial politician tweets out a paper on myocarditis related to a COVID vaccine. The long-form article makes you think about the bigger picture of science interpretation. While COVID brought more intense politicization of some topics in science, the abuse and misunderstanding of science long predates the pandemic. And in one part of the features article, the author considers the role of scientist. Quoting an expert, she wrote, quote, "The way science hits the world is part of science." Quote, "Modern researchers should think about the social context of their work." Now, having been embroiled in this mess, in the before times, when I foolishly thought critical appraisal could be applied to COVID science as if it were statins, stents, or ablation, I have thought a lot about the presentation of evidence in the digital landscape. In fact, my grand idea of this podcast is not just to help with specific issues in cardiology, but more to create a culture in which critical appraisal is normative. Some comments. First, there will always be bad actors who can twist a study's findings. Supplement and vitamin sellers, politicians, for instance, will always do this. But here is my idea. Imagine a populace, a society, who had a different view of how science worked. Society that understood how much uncertainty there is, how most things we test don't work, how science is a process of knowing, a process that does not finish. If this process of knowing was the normative view, there would be less market for dubious actors to work in. If doctors held such norms, there'd be a lot fewer left atrial appendage closures, for instance. My conclusion, and I know many of you will disagree, and please, it is okay, please disagree. My conclusion is that I think society's struggle with medical science is largely on us. I've co-authored a paper documenting the shocking amount of spin in the cardiac literature. Spin is when authors use language that distracts from a non-significant primary endpoint. Every single time an author spins a scientific paper, cynicism and distrust is advanced. It may seem like a nothing thing to do to emphasize that silly surrogate endpoint or subgroup, but it shreds confidence in our profession. This month we had a decidedly non-significant trial looking at embolic protection devices after TAVI. The primary endpoint did not get close to reaching statistical significance, yet at the meeting the authors of the study, many of whom are proponents of the device, diverted attention to a secondary endpoint with small numbers of events. And then in the conclusion of the published paper, they added a phrase suggesting the confidence interval did not exclude the possibility of benefit. And at HRS this May, prominent researchers presented a study comparing two types of ICDs. The ATLAS trial had a primary endpoint with 5 components, 4 of which could only occur in one arm. Now, when the newer, fancier ICD proves superior, and of course it would, the next day Boston Scientific was publishing ads with the positive results. These are just 2 of many examples. Our literature is replete with stuff like this. Now, here's another comment, another thing that we take as normative that average people find shocking. I've heard Joe Rogan rant about his discovery that scientists who publish papers don't have to show their data. Regular people hear that and think, wait, the only people who see the data are the authors? And the first time I submitted a poster, 10 years into my career, I just decided to do this, I was shocked to learn that no one would look at our Excel database. They just trust you, John, said one of the co-authors. And then there is the process of codifying standards of care. In many cases, not only do the proponents of a therapy do the study, these same authors also write the guidelines which then establish what doctors do and payers pay for. And then comes the medical reversals, which can overturn a therapeutic fashion. Look no farther than the cardiac cooling after cardiac arrest story. This began with extremely weak data. Then trials came and showed no benefit, and still there was no change in practice. Not until a much larger trial was done has practice begun to change. And of course, you would argue some degrees of medical reversals ought to be normal as knowledge changes, but you hardly ever see leaders get up to the microphone or pen editorials about how they were wrong and what they learned from the process. The model of science we now embrace borders on anti-science. We have proponents of interventions doing studies largely designed to show it works. Much of a bias in a trial comes in its design, say the choice of uneven run-in periods or weak comparators or dubious endpoints. And don't even get me going on selective reporting of endpoints that you don't like. Hint, universal definition of MI. So disordered is the use of medical evidence that devices that fail to reach lax non-inferiority margins become standard. Yes, the pivotal regulatory trial of left atrial appendage occlusion prevailed, did not reach non-inferiority in its first co-primary endpoint of stroke, systemic embolism, and CV death. And missing such a lax non-inferiority margin should tell an important story, but now this procedure is normative and advertised to patients by doctors and hospitals alike. This model of science sows cynicism and distrust. Now, even when a new therapy actually works, it becomes less believable. My arguably naive solution would be that content experts and proponents of procedures be less involved with the design, conduct, and especially interpretation of the trials that test these therapies. Methodologists who have less skin in the game ought to lead the trials. Big industry ought to fund more basic science, and phase 3 and 4 science funding should come from the government. Guidelines. Here's another idea. Guidelines should be narrative reviews written by neutral parties. I would do away with those silly boxes that summarize recommendations as if patients fit neatly into an algorithm. The narrative and evidence review of guideline documents are often wonderful ways to learn the evidence base. That is enough. We don't need the boxes. Doctors are smart. Finally, mostly, I would want public-facing scientists to always lead with uncertainty. We don't exactly know, but here is what we think and why we think it, and here's what we're going to do to learn more. And the corollary, since we know so little, there's more room for equipoise. And this might create a culture of randomization where we randomize more patients. When I was in Scotland, I heard a colleague say, the only way we could get that device is if it were in a trial. That's what we need more of. Science would actually advance faster if we properly studied things before adoption. Medical science needs to heal itself. Okay, final topic today. Diabetes as a risk factor. JAMA has published a very interesting research letter from Canadian authors who used administrative healthcare data from Ontario to study the changing association of diabetes and cardiovascular events over the past 3 decades. Their findings are provocative because diabetes has always been one of the scariest risk factors for disease. Here's what they found. Diabetes prevalence has increased substantially. 1994, diabetes was 3.1%. In 2014, it was 9%. And I bet if this was done now, diabetes prevalence is way higher than 9%. Back in 1994, the presence of diabetes increased the risk of having a cardiovascular event by a factor of 2.1x. But in 2014, the presence of diabetes increased the risk of a cardiovascular event by a relative risk of only 1.6x, so less. And as a comparison, the authors also looked at the presence of cardiovascular disease as a predictor of a cardiovascular event, and the relative risk of having an event with having prior CV disease was also about double, but it didn't change over time. Now, the message here could be that diabetes of new may not be as bad as the diabetes of old. It's still, of course, a risk factor, but at least in this one study, it was no longer equivalent to having prior cardiovascular disease. Now, the authors attribute this to advances in the treatment of diabetes. That's possible, though I don't think there was much SGLT2 inhibitor or GLP use in 2014. Another factor, especially when using administrative data, could be the lower thresholds for the diagnosis of diabetes. I highlight this research letter not to make light of diabetes as a risk factor, but highlight the changing environment in which new therapies are tested. One of the topics I spoke about in Edinburgh lecture was that trials might need expiration dates. Take ICD therapy for non-ischemic cardiomyopathy, for instance. 20 years ago, ICDs for primary prevention reduced mortality, but the more recent Danish trial in 2016 found absolutely no mortality benefit to having an ICD, which is likely because of decreasing sudden cardiac death rates along with better background therapy. Beta blockers after myocardial infarction may not be useful in the post-reperfusion era is another example. And now we have diabetes becoming less of a risk factor. The point is that times change. And the final reason to highlight this paper is that it is a good use of observational data. Instead of making or trying to match two non-randomized groups and making causal inference, this group is reporting on changing trends of association over time. That's a good use of observational data. So that's it for this week in cardiology. But remember, next week is the AHA starts on Saturday. So on Friday of next week, I'll have some preview of that, a big meeting. As always, I'm grateful that you listened. Thank you. And remember, friends, if you like this podcast, please take the time to give us a rating. Even those little 1 or 2 sentence reviews helps others find us. Until next Friday in the AHA preview, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.